Today it's going to be a long case, very long, maybe even in two parts. I had a patient. This is how the patient came. You can see she had one upper bridge, one lower bridge. Some of the teeth, almost all of the teeth under the bridge are problematic. She has caries, she has inflammations, she has a lot of things. And adding to all of that, you can see the aesthetics are not perfect. You can see that the height of the canines is different. You can see that the height of the central incisors. You can see that the second incisors are different size.
It's a porcelain bridge?
Yeah, it's a PFM bridge. You can see that the central line is not perfectly aligned. You have a lot of small problems, but the main reason why we want to change those bridges and extract the teeth and do implants is not the aesthetics, is the caries and the teeth under those bridges. First of all, because her relations are quite correct, the vertical dimension of the occlusion is fine. We want to change the bridges one by one. We don't want to do everything from the start. This way we can use the vertical dimension that she has right now, and the final bridge will be with the same vertical dimension.
So you're keeping the relation that she's already had?
Yeah.
And you just go with this?
Exactly. The relation is not something that I want to change. She got used to those relations, she had those bridges for a long time, she wants to stay with them. I just want to change I need to extract the teeth, and I want to change the bridges to new bridges, and I want the new bridges will be in the same relations. So this way it's much simpler for me as a doctor to do it one bridge at a time and not everything from the start. It's also possible to take relations and do everything in one time. This time we decided to take one bridge at a time. You can see that we extracted all the teeth. We placed implants. You can see that all in all we have 8 implants for a bridge from second molar to second molar.
It's on multi-unit level also?
Yeah, the implants are quite parallel. We don't think that will be a problem. And we placed multi-units. Right after the implantation, we took impressions. Now, it takes some time to make a bridge. So in this case, we released the patient with healing caps on the multi-units for about a day or two until we made a new provisional bridge on those multi-units. The second thing that we'll see is the healing caps on the multi-units. You can see all the healing caps, all the multi-units. You can see it's still bleeding a little bit. This is how she went home.
For 2 days?
For 2 days, yeah, for 1 day. We try to schedule these operations so that everyone, the technician, the doctor, the surgeon will be available, so she'll get the provisional bridge as fast as possible. If it was done in the morning, in some cases, by the evening you can already have a bridge. We all do it in the same day.
This is the bridge?
Yeah, this is the bridge. You can see that this picture was taken after it took some healing process. You can see that the gingival color is somewhat better. You don't see all the blood and the inflammation that was because of the surgery. You can see that the relations are the same as they was before. And this was taken about a week or so after the operation. You can still see that there is no complete healing of the gingiva, but everything is much better. Now we'll send her home for about 3-4 months. And after 4 months, when she'll come back, we'll start changing the lower bridge. Also extract the teeth, place implants, and make a provisional bridge.
Same procedure as well?
Yeah, same procedure. After 4 months, you can see she came with a bridge, and you can see the main reason why her teeth were extracted in the first place. You can see that no hygiene at all, almost. You can see all the plaque around the crowns. You can see inflammation around the crowns. It's not what I want to see after 4 months, after the healing process was done. I want to see clean crowns. Right now, it's not the ideal situation. It's not the ideal thing to see after you send the patient home and he comes back after a few months. You can see the screw channels, and you can see the material of the screw channel is a little bit different color than the material of the original bridge. And you can see that the screw channel will go out from the buccal part. So in this case, maybe we need to consider changing the straight multi-units to angulated ones. Now, we placed the implants on the mandible in 2 steps. The first step, we took off the bridge, and we placed about 5 implants. You can see that we have an implant around the second molar. We can have an implant around both canines, around the second premolar and second molar also. And we returned the bridge, the PFM bridge that she had. We gave those implants some time to also integrate. Then in second stage, we've added some more implants because 5 implants for the lower jaw is a little bit problematic. You can see that you have a large spans, and if we want to have a zirconia bridge, you can't have 1 implant around the second molar and the second implant around the canine. Nothing will hold. You'll have a discementation, the bridge will break. You don't want to do that. If you want to do a classic colon 4, the implant's supposed to be around the second molar, canine and the second molar, not that far away. In the second stage, we've added some implants around the extractions, and you can see that one of the implant is angulated. Because of the mental nerve, we want to go around the mental nerve, so the implant has mesial angulation, distal angulation. And we know that in this implant, we can have an angulated multi-unit that will correct the angulation of the implant, like in classic colon 4. In this case also, you can see still the sockets of the extracted teeth. You can see the scan abutments. You can see a little bit of blood in the scan abutments. And we took impression from all of these scan abutments. And in second stage, we want to construct some material to have relations for the lower bridge, for the lower part of the bridge. In this case, after we took impressions only from the scan abutments, we will take impressions from the scan abutments with some material on them.
Let me guess, your favorite material?
Yeah, in here you can see that we took off some of the scan abutments, and we've added on some of the scan abutments composite material. The composite material is in occlusion, and you can see that in this case the height of the scan abutment is exactly 6 millimeters. This is probably the smallest height for the restoration that you want to have. In the anterior part you have much more. You can see the height of the composite material. This is the bridge that we took off. You can see that the teeth just rotten. You can see parts of the teeth, the post cores, everything is glued to the teeth. There was nothing left from those teeth. So it's not for the aesthetical part that we took it off, it's from the biological part.
This is the new bridge.
Yeah, this is the new bridge. And you can see that the upper bridge started brushing the teeth a little bit better. You can see the occlusion. You can see that it's not bad, little bit of interferences you can see around the canines in the anterior part that you can correct a little bit. You can see that you have a contact also on the second molar.
It's a lot of contact points.
Yeah, it's a lot of contact points. It's quite good. It's not perfect, but the central line in the center, all of the restoration itself, the aesthetical, the functional part is not bad for provisional restoration, for the first bridge that you have after you took impressions on implants that were immediately placed, immediately restored. It's not that easy to get this type of contacts.
Two bridges, not one.
Yeah, two bridges. Now, after some healing, we can see that the gingiva is starting to form up. You can see the concavity of the crowns. We also made a new temporary bridge, and you can see that the occlusion is much better. Still, maybe we need to have some correction of the central line. It's something that take process. You can't have one temporary bridge and in this one temporary bridge get everything's perfect and go right to the zirconia.
Only in fairy tales.
Yeah, only in fairy tales. It's a process because you have problems, you have different things that you didn't thought about. You have some misalignments in the impression taking process because the blood, the clots, the gingiva, everything is interfering in the scanning process. The main point is that you're not doing it one visit. You need to take the time. You need to take the time to make it perfect. So in the end, you'll get a perfect result. This is still not a perfect result, but it's getting closer. You can see that after some time, we took off the bridge, and you can see the healing of the gingiva, that you have the indentation for the teeth, that it will look like the teeth is coming out of the gingiva. Something you want to form in the process of the temporary bridges. It's also something that's quite important. Now, you can see the third temporary bridge that we had. In this bridge, when she smiles, you can see the upper teeth. The incisors are almost the same size. With implants, sometimes it's difficult to have the same size of the incisors because on one of them she had a long crown, on the second one she had a short crown, and you need to compensate on all of the things she had before. The same as the implants on the lower jaw. So we took those bridges that in the end she was satisfied with, in the smile, in the lip line, in the aesthetic, central line, everything was fine. And now we want those bridges made from zirconia. We take the bridges, and because it's a bridge on 14 teeth, from monolithic zirconia, the best thing to do is not cement the sleeves on the model or in the laboratory. We want to compensate of the inaccuracies, first of all, that you have when you sinter the zirconia. You mill the zirconia from unsintered material, and then you sinter it to a much harder material that shrinks and that have some deformations in the sintering process. So you want to compensate those. You want to compensate maybe from the scanning process, some inaccuracies that you had. So this way we compensate those inaccuracies in the process of the cementation of the sleeves. This is why the process of the cementation of the sleeves we're doing in the mouth. We're taking the sleeves, we're putting them inside the bridge and cementing them one by one or two by two inside the mouth.
So this process of cementing sleeve inside the mouth is the process that corrects all the small deviations that occurs during the scanning process or during the zirconia milling process, right?
Yeah. And what would happen if you glue it on the model?
I think it probably break.
Yeah, because when you attach a zirconia bridge, screw-retained bridge, to multi-units, to any construction, you want to have passive fit. You want that some kind of forces won't be applied on the multi-units or the implants. So this is a method of, let's say, passivation. If you'll cement them outside the mouth, all the inaccuracies will be the same. They'll stay. And then when you assemble the bridge on top of the implants, you have those forces that will be applied on the implants or on the screws on the multi-units. This way you can, some of the forces like nullify, you'll have them passivated.
And so less chance of it to
Exactly.
break.
Then less chance for a problem with the implants, less chance for the zirconia to break. From our experience, this is probably the only way to have a full monolithic zirconia bridge that doesn't break down. What you see here is, first of all, we prepared the bridges and all of the sleeves. with the screws, with everything. Everything is prepared. Now, what we do, we insert some of the sleeves, and we need for the sleeves to hold inside the cavity for the sleeve, right? So, because if you just flip the bridge, everything will fall down. So we use toothpaste. We apply on the sleeve and we hold the sleeve in place. Yeah, it's funny.
No, I remember when
It's
you told it
biocompatible.
last time. Yeah, when the dentist uses toothpaste, it's given. Like, what did the dentist use? Toothpaste. Wow, really?
So 5 sleeves, the posterior sleeves, we're holding inside the bridge using the toothpaste. And now in the first place, we'll cement only the first 3.
The frontal 3.
Yeah, the frontal 3. And then we screw all of the sleeves together. So we'll have a bridge inside the mouth with all of the sleeves, 3 cemented, 5 on toothpaste. You can see the contacts with these 3 sleeves and 5 on toothpaste. Later on, we'll take out the toothpasted sleeves and change the cementation process from toothpaste to real cement.
I see you are one of the 9 of the 10 doctors that recommend some toothpaste.
I wanted to not recommend using them in the mouth, but for cemented sleeves.
It's still a good toothpaste.
And when we cemented all of the sleeves and we take out the bridge, we want to clean the residues of the cement, everything. We don't want to put the bridge inside the mouth and keep it like with all the residues of the cement. Yeah, we'll have inflammation. It's not cemented restoration, it's curetane restoration. So we can take it out, then we can clean all the residues of the cement. And you can see that in some places, fitting of the sleeve into the cavity for the sleeve is not perfect. But we did had a perfect occlusion. So why it happened?
The deviation.
Yeah, this deviation, when we took the impression, the technician placed the scan markers on the impression that we took. Then we milled the zirconia. The sintering process inserted also some deviations. All of these deviations are going one on top of the another, and then in the final process you get some part of inaccuracy. If you didn't do it in the same way, you didn't see these inaccuracies. You just had internal forces in the zirconia bridge, and then after 1, 2, 3 days, maybe a couple of weeks, the zirconia will just crack. And you'll see 2 parts of the zirconia, one is higher than another, for example.
It will just pop.
Yeah. And in here you can see that you have a very small slot between the sleeve and the zirconia bridge. Right now you can take composite material, flow, liquid composite material, just close it up and polish it to have so you don't
you just had some material here and just close it.
And this way you don't have any gaps for bacteria or different type of organisms, or just you can see the same here. Here are the residues of the cement that we had from before. Later on we'll close a little bit the gap that you can see most of the deviation on the posterior sleeves, because if you have any inaccuracies in the center, the posterior sleeves affected the most.
More.
Yeah.
And because you first of all screwed the
this is why we screwed the anterior in the first place.
To see the deviation.
Exactly. The last bridge was the lower one. Now we can see that we have the same with the upper bridge. With cement, first of all, in this case, the angulated abutments, the angulated sleeves. And then in the second place, we'll cement the straight ones, using the same method, the same thing as we talked about before.
And I see you will clean the cement from inside those?
Yeah, when you cementing and you have some saliva or residues of the cement, you just clean it up a little bit. It's very easy to clean. You can see in the posterior parts that the gap is not very small. In this case, if you wanted to make a zirconia bridge and then you attach the zirconia bridge to the multi-unit, you'll have a problem. You had it's not a large deviation because it's in magnification. It's like 0.1 millimeters or 0.2. And all of this deviation is because of the sintering process of the in the modeling program like ExoCAD or 3Shape. You need to position the scan abutment model on top of the real scanned scan abutment. And when you scan the posterior teeth, it's sometimes hard to scan them. And you have like gaps or places that it didn't scan very good. So it's hard for the technician to position the scan abutment model on top of the scanned scan abutment. And you can have also some deviation there also. The higher the scan abutment or the multi-unit, you'll have the bigger deviation. You just close it with composite material for tooth fillings, the same thing, flowable. So it will go inside this slot.
And then you polish it.
Yeah, and then you just polish it. And you have a perfectly fine zirconia bridge, full monolithic zirconia. You know that when you screw the zirconia bridge, you won't have any internal forces because the cementation was when the cementation process was when the cement didn't harden. So the sleeves are perfectly passive. They compensated on those inaccuracies and those internal forces that could have been. That's all. You have a fine zirconia bridge with no gaps, nothing at all. Closed all the gaps with composite material.
I see here you didn't, you chose not to color it pink, just to polish it.
So when you making a full zirconia bridges, the parts that close to the gingiva, it's better not to glaze because this way you minimize the retention of the plaque.
Mm-hmm. You mean the bottom, right?
Yeah, the part that close to the gingiva, because for the upper bridge it's the top part.
What do we have?
You can see here the final bridges.
Screw channel.
Yeah, you can see the screw channel in the first molar. Mm-hmm. This screw channel later on will close and we'll apply a little bit of composite material to correct the color of the screw channel. You can see the plastic pins that we closed the zirconia bridge with, and her final smile with different types of lighting. So in here you can see the bridge is a little bit whiter and here a little bit yellower. But all in all, you can see that all of her teeth in the same level. It's much better than what she had before.
And the midline is great.
The midline is great. The smile line, lip line, everything looks fantastic.
Thank you very much.
You're welcome.
And thank you for being here today. Don't forget to like, share, subscribe, and follow us to stay tuned up to date. Have a great day, and thank you.